Good morning, our colleagues. This is our first GIT Viva hot seat session. We have a very nice collection with 30 cases. Hopefully, it will make a maximum benefit for all of you. Let's start our first candidate, 40 years
Yes,
old male patient, complaining of vomiting and diarrhea. You have the contour.
yeah,
One second.
yeah.
1 second. My voice is audible.
Yes, sir.
Okay. Okay. Let's start.
I cannot scroll the images.
Request again.
Sorry.
Request again.
Okay, okay. Sir, I have requested.
Go on.
Okay. Yeah. I have been provided with the axial CT images of an abdomen of an 40-year-old male patient who is presented with a complaint of vomiting and diarrhea. I am scrolling through the images from top to bottom. First, I will look, then I will comment.
Yeah.
Um, I'm going down. I can see the liver and kidney appears normal to me.
Yes.
I'm going downwards. I can see there is a significant mesenteric fat stranding is noted within the abdomen.
Excellent.
Um, I'm going downwards. Okay, then I'm going again back. I can see that there is some thickening of small bowel loops is noted at the region of the lower abdomen.
Excellent. Could you follow this whole vesicles? Follow it,
I'm
please.
trying. It is not scrolling. I think it is blind-ended.
And so,
Its wall is thickened, and there is some adjacent fat straining is noted here, and there are few subcentimeter lymph nodes are also present. There is no obvious large collection is noted over here, or any there is no any sign of free air noted, which could suggest that this is a perforated. So I'm thinking of acute appendicitis. I'm looking for if there is any appendicolith in this area. I'm not able to find any appendicolith, but there is no perforation. It is acute condition. So this require urgent referral to the gastrosurgeon for further management. And um, yes,
could you show
so
me the whole length of this appendicitis?
yes, I'm trying. Yeah, this is going on that side.
Mm-hmm. Then, yes. Indicate by the mouse. Show me
Yeah.
where is it? Yes.
Hmm.
Okay. Okay. Yes. I. Do you want any other plane?
Yes, I want to see the coronal images.
Yes. To be given. Well, yes. Go on. Good. Mm. Here's the appendix.
Oh, I think not this. Can I bit zoom the image if possible?
No, it is very clear, very clear.
Okay, I think this is sorry. This is the appendix.
No.
Okay, not this one. This
Which holoviscus has the maximum thickening, maximum surrounding uh, string?
it is not over here.
How
Sorry.
could you in practice uh, anatomically trace the correct anatomical location of the appendix? Yeah, tell me
Yeah,
for
I'm
your
tracing the
opinion.
semicolon. I'm looking at the sequence.
Yes, yes. Mhm.
It's bit.
Okay. Don't worry. What else do you want to exclude from the CT in case of appendicitis other than perforation?
Other than perforation, I have to look for free air, any
What
collection
else?
phlegmon formation.
What else?
Um, what else? I like we just know that whether it is perforated or there is a phlegmon formation. Is there any acute condition? Um, like the appendix is, the wall is like enhancing. It is not a gangrenous.
Okay. Thank you, doctor. Thank you. You did very well. Take a to-home message. First, first, in any male patient with severe abdominal pain, first to be excluded appendicitis until proof otherwise. Okay? Until proof otherwise. Second, when you are assessing a case of appendicitis, you should tell the examiner, like you said, I should exclude any perforation. Okay? I should exclude also thrombosis of either portal vein or mesenteric veins. This is very, very important. See here, doctor. Okay. How can we detect the appendix in any patient, even if normal? We go to the ileocecal junction. Okay. Ileocecal. This is, by the way, not the best case but generally we go to the ileocecal junction. Okay. And then from behind, especially you should see the ileocecal valve. You should see the ileocecal valve, and then you will detect the appendix from behind. Here, due to the severe, thank you, doctor, so much. In a male patient, next candidate, let's start. In any male patient with acute abdomen, you should tell the examiner, doctor, I wanted to have a look to the right iliac fossa to exclude appendicitis. He will respect you too much. And if you find any signs of appendicitis, doctor wanted to exclude perforation, localized formation, and mesenteric thrombosis. Very nice. Like this, you smashed. Thank you so much, doctor. Next candidate.
Yes, sir. Good afternoon. Candidate 2 here.
Yes.
Am I audible?
Yes. Yes.
Okay.
First control, please.
Yes, sir. I have requested the control. So,
Yes. This
yes,
patient have
okay.
severe
Mhm.
abdominal pain post interventional process. Go on.
So, okay. This is a CT scout image of the. This is CT scout image of the patient, where I can, of including the chest and abdomen, where I can appreciate there is at the first, I can appreciate there is a thin rim of air just below the diaphragm. So this is concerning for pneumoperitoneum. This is the emergency finding, and I will inform the referring physician for the and surgical team for the management. Apart from that, the lung parenchyma is unremarkable. However, right lung volume appears to be reduced. Also, and with elevated right hemidiaphragm, there is some sort of tubing or instrumentation is noted below the right diaphragm. Continuity I am unable to trace in this one. The continuity of the tube I am unable to trace. Apart from that, in the abdomen, I can see that there is a gas-filled prominent transverse colon. However, the paucity of air is noted in the lower abdomen, especially in the lower abdomen and the pelvic region and rectal region. Left diaphragm also appears slightly heterogeneous. So for this, I will suggest for an urgent CT scan to locate the cause of pneumoperitoneum. And
Do you want anything else?
CT I would like to do CT abdomen, CT abdomen pelvis. Okay. So yeah, sir, okay, sir, I move. Yeah, okay. I'm control. I'm taking the control. Yeah, I've been provided with CT scan, axial sections.
Yes.
Of chest and abdomen. But lag is there. Just okay. Yeah. So I will just I'm scrolling from top to bottom. Yeah. So here in the this is the city of abdomen, and here I can notice. Yeah. In the in the gallbladder, I know there is a significant collection of contrast is noted in the gallbladder, and also in the biliary tree. I think it has any. I think any recent ERCP or some contrast study was done for this. Apart from that, I see some tube. Yeah. Okay. So instrumentation has been done. I see the tube running through the course of CBD. It's difficult to control. Apart from this, there is some air foci along the course of CBD coming below in the abdominal region. I notice. Sir, can you please scroll? It's very much it's moving this that way. It's not able to scroll. Hello, sir. Hello.
Yes, I'm scrolling.
Yeah. Okay. Yes, sir. In the pancreas appears unremarkable. I would like to see the liver, sir, and liver and yeah, liver. Coincidentally, I noticed bilateral right lower lobe collapse also is there, and then in the liver there is a heterogeneous area of low enhancement and attenuation, which is in the segment around segment 4.
Yes.
Then okay. Liver. Biliary tracts are slightly prominent on both sides, and then porta. This hypodense area could be is extending to the porta region, so it could be some nodes in porta hepatis also. Okay.
Yes.
Then
Look here.
some air loculi are okay. Yeah, here I noticed that there's significant subcutaneous, I mean, air loculi are noted in the retroperitoneum and in the retroperitoneum, and also in the in intraperitoneal air, free air is also noted. Yeah.
Yes.
And so pneumoperitoneum and pneumoretroperitoneum is also there.
Could you give me a diagnosis, please?
So with this finding of pneumoperitoneum and pneumoretroperitoneum, and right? Lower lobe collapse and liver hepatic lesion in liver post. This appears to be. I would like to know the history of the patient, about the history of the procedure which was done, and
No history available,
I have no
but you
history
have
about.
some finding.
Okay.
You have some finding here.
This okay. So
You have some finding.
this is the that I can also see the some that I think this is the contrast in the this is the contrast in the T and the CBD and coming here.
Oh,
Yeah,
so
there is some focal. Yeah, there is some focal area of enhancement is noted at the sphincter of Oddi, periampullary region, which might be causing the dilatation.
okay, give me a definite diagnosis, doctor.
Okay.
What is the name of procedure done here?
This is this is ERCP. I mean PTC
Excellent.
ERCP as well. Yes.
Complicated by? Yes, complicated by
Complicated by pneumobilia and also free air in the peritoneum.
pneumoperitoneum. Due to
Yeah,
what happened?
yeah.
What caused this pneumoperitoneum? What is the cause?
Uh, some perforation of the cystic duct or CBD.
No,
I'm looking.
no.
Okay. Yeah.
One organ must be
Yeah.
other than
There
that.
is some there is a focal area of thickening in the duodenum, so this could
Yes,
be
so
because of duodenal perforation also.
thank you so much, doctor. You did very well.
Yes.
Okay,
Yes.
take some home message. This is, you
Yes, sir.
didn't
Yes, sir.
ask for lung window. In every case
Yes.
you suspect
Okay.
or you see some pneumoperitoneum, you should ask the examiner. He will change to lung window.
Yes.
If you
Yes.
change to lung window to, you will find another disaster here. There are
Okay.
a
Yes.
pneumo right-sided pneumothorax.
Mm,
Plus, there are
Yes.
surgical emphysema extended up to the neck.
Up to the neck.
Plus, see this pneumorachis?
Mm. Okay.
See?
Yes. In the spine, in the spinal cord,
This is,
in the
yeah,
spinal canal. Yeah.
a typical Viva
Mm,
exam case. Okay?
Yes.
This is a typical also
Mm,
long reporting case. Just he wanted
Yes.
you to enumerate what you are seeing. This is not only
Yes.
pneumoperitoneum, but there are
Mm,
pneumoretroperitoneum because the kidney
Yeah.
is a
Yes.
retroperitoneum.
Mm,
So,
mm,
doctor, after you describing, all of you, my
mm,
colleagues, we
mm,
should conclude. Doctor, I'm presenting with case of pneumoperitoneum, pneumoretroperitoneum, pneumothorax, with a finding consistent with ERCP. So this is a post-RCP duodenal perforation. Like this,
Okay. Yes.
we
Yes.
must conclude. Thank you, doctor, so much.
Yeah.
Candidate
Thank you,
number
sir.
3,
Yeah. Thank
welcome.
you, sir.
Number 3.
Hello, sir. Good afternoon, candidate 3.
No. Yes. My colleague, before I start candidate 3, I want to have comment here for first case because it was very difficult. This is a very big dilemma to pick up appendicitis into the appendix here. See, this is the appendix. Very difficult. So, see, just anterior to the this one, by the way. Anterior to the external iliac vessels. Anyway, see this one. This one. Okay. Even I'm trying to trace to the base. Very difficult also. يعني, see, this is a blind-ended structure, and here don't disappear. Also in axial, Did it. Anyway, it was the appendicitis. This one. Okay. I'm sorry for confusion, but even here in axial, uh, can't be traced till its base. Okay, this is appendicitis. It disappears here. According to this loop, this is ileitis, surrounded by localized peritoneum. Okay, my colleagues. Number 3. Number 3, are you ready?
Yes, sir.
Okay. 55-year-old female patient with long-standing diarrhea, weight loss, and iron deficiency. Go on.
Here I am presented with the contrast. Here I am presented with the CT scan of the abdomen, axial sections. Sir, is taking some lag. Can you scroll for me? Okay, now it's working. Okay, I am presented with the non-contrast enhanced CT scan abdomen, axial sections. Here the oral contrast is given and patient presented with the long-standing diarrhea and anemia ST is there. In this, I can see that the jejunum, the ileal bowel loops, there is a increased jejunum conjunctivis are there.
Excellent.
So that is the reversal pattern of the reversal pattern due to the celiac disease. So
Yes.
that can lead to the reversal pattern. And
Yes. So, what's your diagnosis?
then I am looking for any lymph nodes because that can be the complication of the celiac disease. There are few subcentimetric lymph nodes are noted in the mesentery.
Celiac disease. What is the appearance of lymph node? Could you describe? No. No.
I want to.
Yeah. The usual appearance of lymph node in celiac disease. Could you describe the appearance?
Yes, in the celiac disease, the lymph nodes are there in the mesentery, but they are not necrotic lymph node. There is no evidence of any calcification within the lymph nodes. I am checking for any thickening within the bowel loop to rule out any lymphoma.
Did you find?
No, I want to go for the contrast image.
Is it? Okay.
There is then I am checking for other finding as well. There is no evidence of obstruction is there. I cannot see any pneumatosis is there. No evidence of any pneumoperitoneum or adjacent ascites is there. Portal, no evidence of air is within the portal vein.
So your final diagnosis, give me final diagnosis.
The final diagnosis that this can be the celiac disease that can lead to the reversal pattern. The prominent.
Could you tell me, please, the underlying pathology of celiac disease?
Celiac disease due to gluten deficiency. Gluten
On
intolerance is
deficiency.
there. Gluten intolerance is there. That is
Excellent.
allergy to the gluten.
What is the complication of celiac disease?
Lymphoma, the T cell lymphoma can develop.
Thank you, doctor. You did very well. Leave the mouse.
Okay.
Thank you. Doctor, thank you. You did very well, except 1 point. This is case to be smashed within 1.5 minutes, 2 minutes maximum. And you pick up the finding from the beginning. You should shift without I ask you either you ask me the chronal to confirm. As you see, my colleagues here, there are increased thickening and the number of fold in the area. However, in the duodenum decreased. So this is a reversal pattern, duodenal fold reversal pattern. Okay, so this is very easy to tell the examiner this is a celiac disease. Lymph nodes, there are multiple lymph nodes, but it's not cavitated. See the lymph nodes. My colleagues better to assess the multiple lymph node. Lymph node better to be assessed in post-contrast Ronan. See, multiple innumerable. Second point, you did very well when you told me I wanted to exclude any mass, any lymphoma, any adenocarcinoma. Thank you, doctor. You did very well. Celiac disease is an autoimmune chronic gluten intolerance condition. Thank you so much. Next candidate.
Thank you, sir.
Next candidate.
Yes, sir, I'm next candidate. Assalamu alaikum.
Severe abdominal pain.
Okay.
Would you request the control, or shall I
Yes, sir.
solve for you?
I will try controlling it. If I cannot, then you can please. Sir, I have requested the remote.
Yeah.
Okay. This is post-contrast axial
One
portal
second.
venous.
Yeah,
Okay,
go
sir.
on.
Okay.
Please.
This is post-contrast axial portal venous phase of CT abdomen of a patient who presented with pain abdomen. First, I will scroll through the images from top to bottom, and then I will start telling what can I see. So in this topmost sequence, I can see that there is a mild thickening of the esophagus with some fluid material within its lumen. Going down, I can see that there is some atelectasis and minimal pleural effusion on right side. There is subcapsular ascites. There is also pleural effusion on left side also. And now I'm going down towards the abdomen. Here I can see the liver appears normal. The stomach is grossly dilated. Some fatty changes are noted in pancreas that can be age related if the patient is adult. Some diverticular disease is noted along the ascending colon. Going downwards, spleen is normal. Kidneys are also normal. There is also diverticular disease noted along the descending colon as well. Some air fluid levels are noted in the duodenum, which is also, I suppose it's ileal loops, which are also showing somewhat thickening. Mesentery is misty. There is also evidence of minimal ascites. Now I'm going downwards. I can see that there are areas of mural thickening of the small bowel noted. However, I am going to scroll down. So there is in the pelvis, there is also some mild ascites also noted. In my routine practice, I would scroll through the coronal window and the lung, coronal sections and the lung window also to see if there is any perforation or any other complication. There is an incidental lipomatous or fatty lesion in the muscles of the buttock, I guess. It's gluteus maximus left-sided. There is also some mural stratification noted along the ileal loops in the pelvis. So I guess there is mild element of sacroiliitis also, but I will confirm it on bone window. So keeping in view all the findings up till now, I will keep the differential of inflammatory bowel disease, such as Crohn's disease in this scenario. Second differential will be
The patient looks like all. Don't
okay.
revise what you said. Revise
Uh,
diverticulosis plus
yeah,
fatty
yeah,
infiltration of the pancreas.
yes, sir.
Mhm.
Mm. Sir, can I want to see if there is any vascular, but I cannot see any thrombus in the any artery or in any vein, but I will confirm it on coronal sections if you allow me to.
Don't worry about the vessels.
What, sir?
Don't worry about the vessels.
Okay, okay, the vessels are normal. So it can be some diverticulitis, I guess, because there in the pelvic loops, I guess probably it's sigmoid colon. There is significant mesenteric thickening and fluid noted around these diverticuli.
What else?
So there is what's it can be what else? I will see the hernial orifices, but there are no signs of obstruction. Mm. So it is somewhat some diffuse disease which is involving uh, whole of the large bowel.
Leave the mouse, doctor. Leave the mouse.
Uh,
1 second.
what, sir? Okay,
1
sir.
second. Leave the mouse.
Okay.
Doctor, you came here and you didn't give here what the proper time, the proper
Okay.
history.
This is,
Look
I
here,
guess there is.
please. Look
Okay.
what happened here.
Um.
What is this? 1 second. What? See? 1 second.
Okay. Okay, sir. Okay,
One
sir.
second. 1 second. What happened here? What is this? What is
Sir,
this?
sir, it is some world appearance of the bowel. It can be uh, intussusception, but I will see it on the coronal images to confirm.
Again, doctor, look 1 second. What is this?
Uh,
Look at this
so
outside.
this
Hmm.
okay. So this seems like an abscess with some area of air within
Patient
it.
has no fever. Patient only has
Okay.
acute, severe, sudden abdominal pain.
So
Again,
then,
see?
okay,
1 second,
okay.
1 second. What is this?
Effusion and
Okay.
pneumoperitoneum is also there.
Yes.
Yes, sir.
Yes. Neoprotene.
Yes, sir.
Okay, excellent.
So, yes,
What
sir.
is this?
This
What is
there is
this?
also so this is I guess point of transition in which there is some um,
No
I
point of
think
transition. Hmm.
it's perforation basically because and the air of locule is also noted in this region, free air of locule in the
Yes.
peritoneum.
Free air
So this is
locule.
point of perforation.
Yes, and the free fluid. Okay.
Yes, yes, sir.
Have another look to the pancreas, please. Here. It's very
Yes, sir.
difficult. Look
Yes,
at the
sir.
tail.
Look at the tail of the pancreas.
And there's the neck.
Um,
Hmm.
so there is also so there are some fatty changes, fatty replacement of the pancreas, and at this region there is also some thickening of fatty strandings noted at the pyloric and entral region of the stomach as well. And I can see that there
My
is
colleague.
suspicion of
Yes.
okay.
Yeah. What is this? Yeah. Tell me.
So it's an enhancing lesion, I guess.
Excellent. One enhancing lesion
So
here.
yes,
Look,
sir.
look, look. What is this?
So the thickening and perforation, so bowel wall thickening.
This one also. It is very difficult case, by the
Okay,
way.
okay,
By
sir.
the way,
Another.
difficult case. Yeah.
Sir, it can be some metastasis to the pancreas, or it can be multiple pancreatic islet cell tumors, which are enhancing on.
Excellent. So please build up your diagnosis. bowel perforation plus two pancreatic hyper-enhancing or hypervascular lesions. So give me a logic differential diagnosis, please.
Bowel perforation and two pancreatic.
The two pancreatic hyper-enhancing lesion.
Yes, sir.
What type of islets tumor? Which type? What is the name?
It can be VIP-oma.
What else?
But there are
what is the two most common?
gastrinomas
Yes.
and insulomas.
Excellent.
So it can be Zollinger Ellison.
Excellent. Thank you, Doctor, so much. It was very difficult case.
Thanks.
Welcome. Next candidate, I will explain the case because it is very long extended case scenario. I guess,
Okay, sir.
in my humble experience, due to the new rules of the Viva, you must be presented with a long case scenario, multimodality, because RCR have limited the number of cases, showing cases up to 12. I tell you, at least we were presented with 24 up to 25 cases in the previous age. Okay, so they must give you one long extended case. Next candidate.
Assalamualaikum, sir.
Doctor, this patient, the same patient, we did an MRI. Okay.
Okay,
this
sir.
is the MRI.
so
Shall I scroll
is,
for you?
Yes, sir. Please scroll for me.
Yeah.
So these are axial sections of the MRI T2-weighted sequence, in which I can appreciate.
This is not T2, doctor.
So there is a fat suppression of the pancreas due to the lipomatous infiltration.
What is this?
Sir, there is a thickening of the bowel.
What is the name of the sequence?
So this is T2 fat sac.
No.
Sorry, axial DWI. Sorry, this is axial DWI.
Yes, excellent. Very important.
So I can see. So I can see restriction of the restriction in the pancreatic lesion.
Excellent.
So I would like to confirm on ADC as well.
This is the ADC. I think this is ADC.
Yes, sir.
This
So
this I think this is the same.
So this confirms the restriction of the lesion. So this is actually arterially enhancing lesion in the region of head of pancreas.
Look again at the pancreas. Look again.
Okay. So medial wall of the duodenum.
Okay, here this is the tail of pancreas.
Yes, the tail
your
of the
colleague pick up two hypervascular lesions.
Yes, sir.
What is this?
So this, sir, it also shows the restriction on DWI. So this is likely islet cell tumor.
Okay, what is this sequence?
Sir, this is a post-contrast sequence, axial post-contrast T1 weighted MRI.
Excellent. What happened?
Sir, this lesion. Sir, this lesion shows avid post-contrast enhancement.
Where is this lesion?
Sir, could you please scroll up?
Here?
No, sir. Sir, I cannot appreciate. Sir, is ISO to the. Yes, sir, I can see now. This is a well circumscribed enhancing lesion in the tail of pancreas.
Excellent. You mean this one?
Yes, sir. Yes, sir. Yes, this one.
Excellent. And then equal. This is artery, by the way. 1 second,
yes, sir.
colleague. Hello?
Hello, ji, sir.
Yes, yes, yes. Okay. We can hardly see in the post contrast the tail one. We are not sure.
Yes,
But the sure one is the diffusion weighted sequence. This
yes,
is
sir.
restricted. This is
Yes.
restricted. Even in Radiopedia answer, they didn't talk about the contrast. So give me your differential diagnosis, my doctor.
Sir, sir, this could be due to islet cell tumor with associated, sir, most likely gastrinoma and
What
those
what will
produce.
you do next?
Sir, I would like to ask for sir, functional studies like scintigraphy for further confirmation.
Yes. This is post-operative. No need for it. Yes. Other than the radio isotopic scan, what should you do for this patient?
Okay, sir, I would, sir, I would like to go. I would like to see, sir.
What islet tumor? What's the common association for pancreatic islet tumors?
The Men's syndrome with the Men's syndrome.
Excellent. So what is other investigation should be done?
So I would like to do parathyroid ultrasound to rule out parathyroid adenoma. Ultrasound
Excellent.
next.
If I show you, this is an ultrasound thyroid.
Yes, sir. So this is one of the static image of ultrasound of the thyroid gland, and that reveals a well-defined hypodense lesion in posterior to the thyroid gland. So this likely represents large parathyroid glands, likely
Yes.
parathyroid adenoma.
What's
So would like to
what's your next step?
So I would like to correlate with the history and as well as the serum levels of the parathyroid hormone.
What else?
So scintigraphy can be done to confirm the diagnosis.
Okay. This is one of the isotopic scans. What is the name of this scan?
Sir, this is MIPG, system EB.
Excellent.
Sir,
What happened
sir,
here? Here? Could you describe, please? No.
that demonstrates uptake within bilateral, almost symmetrical and bilateral uptake.
Could you tell me again, because my internet interrupted.
Okay.
Again. What happened here?
Okay. So this is one of the static image of the delayed system AB scan that reveals bilateral and almost symmetrical bilateral uptake within the parathyroid gland, more so on the right side. Similar as a bilateral uptake is also noted within the salivary glands as well.
Tell me, please, your diagnosis. What happened?
So there is enlarged increased uptake is seen on the right side. So right-sided parathyroid adenoma with coexistent.
Thank you. What you will do next? Do you want to do another scan for another organ?
Sir, for organ of Zucchero candle, sir, to see any paragangliomas associated with the disease.
Something important. Could you tell me what type of men this could be?
So this
1, 2, B, 2A.
So I think this is men 1, sir.
So what is the organ? What is the
third
adenoma? Excellent. Look here.
Yes, sir.
This is post contrast.
Yes, post contrast MRI of sagittal images. Sir, I can see there is a well-defined hypo-intense lesion in the posterior aspect of the.
This is post contrast. So this is hypo.
So
Hypo-intense or high?
non-enhancing, sir.
Okay, hypo-enhancing or enhancing. So what's your diagnosis here?
Sir, this is likely pituitary microadenoma.
Okay, excellent. So conclude all the case.
Sir, the constellation of findings of pituitary microadenoma, parathyroid adenoma, and pancreatic islet cell tumors are in keeping with Menvin syndrome.
Thank you so much, doctor. This is fantastic case scenario. The case started from an acute medicine. Okay, acute medicine. I have some notes for candidate, the first candidate who started this case. Doctor, you did very well, but after 3 minutes, you gave me a lot of sporadic, non-integrated information. You start talking about esophagus, then fluid, then see, you missed this one. Then you came here, there are some alarming signs. My friends try to first scroll all the image. Then you are intelligent enough to tell yourself, oh, this is a case of this region. Why I see multiple finding here. Let's concentrate here. Oh, there are smudging. There are air foci. See, 1, 2, 2, 3. And the bowel here, at least tell yourself, this is abnormal bowel. If you tell the examiner like this, okay, if even you didn't give him a definite diagnosis, but at least you pick up the key of the disaster. Okay, see, very large foci of air here. So this is perforation. This is perforation. At least, if you told me this is a perforation, I will pass you. Even there are another 2 important finding here. There are a calcific lesion here. This is, I think, this is calcification because we didn't have, see, there are calcification here. We didn't have pre-contact. And at the tail, pancreas in elder age is very important to examine with because it is a tricky. See here? So to hyper-enhancing pancreatic lesion plus perforation equal to Langer-Ellison syndrome or gastrinoma. What will you do next? First, I will immediately calling the surgeon for further laparotomy and repair like this. Okay. And after that, I want to search the patient for signs of MEN type 1 or 2, whatever, MEN syndrome, multiple endocrinal neoplasm syndrome. This is the MRI, which confirms the diagnosis. And why MRI here important? See the importance of diffusion. The lesion is very clear here, very clear. But in the arterial, really, you even in Radiopedia answer, they didn't talk about the post-contrast arterial enhancement. So MRI confirmed the lesion. Okay. Then this is post-operation, post-Whipple. They remove the tumor and make some and repair. See the repair here. The repair at the duodenal junction. Okay. And I think this is Whipple operation because I see the stomach. This is the stomach. Okay. This is the stomach, and there are connection down. Connection. Both of you forget to tell me, doctor, there are not hepatic metastasis because gastrinoma is common to metastasize. Okay. No problem. This is acceptable here in our session, but this is a very important home message to keep in mind to avoid it during examination. Then I am waiting from you, from any both of you, to ask me, doctor. I will scan the patient thyroid scan, rule out parathyroid adenoma, and if possible, this is a parathyroid adenoma. Okay, this one. And if possible, I will do dynamic pituitary MRI. This is a pituitary. This is a parathyroid adenoma. Then I give you this scan. I concentrate in this one, system maybe. In the delayed, this is the delay. This is the error. This is the delayed. This is the delay. So right-sided parathyroid anemia. Okay. Then you wait. All of you, both of you are waiting me. The examiner will not accept like this. Anyway, there are hypo-enhancing pituitary microadenoma. So we are dealing with men type 1. Men type 1. Thank you so much. It was a very long, difficult case. Next candidate. No. Next candidate. Any candidate ready? No. No.
I'm ready, but I'm far down the list. So if anyone's before candidate 15, then I'm happy to go ahead. But if anybody else is there, then it's fine. I think the next candidate
Anybody
6.
ready? Okay, Dr. Bon. Request the control, please.
Hello.
Yes, I will proceed with this candidate. Please, my colleagues, save your time and my time. Be ready. Be ready. Doctor, can you start? Request the control.
Sure, I can request control if everyone's okay with that. I'm candidate 15.
Yeah, you can. You can.
Okay.
Request control.
So I'm requesting control now. I've requested control.
Doctor, his patient presented post-surgical severe abdominal pain.
Okay, I'm presented with axial portovenous phase, abdomen and pelvis. I'm just taking a moment to scroll through the images, and I'll speak as I scroll through to see if I can see any immediate findings. So I think I started off scrolling from the mid of the abdomen, so I'd like to scroll from the top to bottom. Okay. Immediately of note, I can see some locules of air seen in a central distribution. This would be in keeping with pneumobilia, as it does not extend to the periphery.
Okay.
I can see that there is adjacent fat stranding. The gallbladder is not well demarcated. It seems partially collapsed. And there's some tethering of the small bowel to the adjacent anterior abdominal wall. There's no evidence of any bowel obstruction of the small bowel. They're relatively small in caliber. I can see that there's post-surgical clips from possible surgery. So previous small bowel hemicolectomy or hemiresection of the small bowel. I'm just looking at the rest of the lower abdomen.
What is the colon? You can
Sorry?
see the whole colon. Why you
No.
said hemiclectomy?
So I can't see
This is
the
not
entire.
hemiclectomy.
Yeah, this is not
Okay.
Sorry, that was a mistaken statement. It's not hemicolectomy. I think it's just a small bowel resection that has been occurring, and there's ileoileal anastomosis.
Okay. So what
Just
happened?
looking.
Tell me what happened.
So my primary differential in this case with some subcapsular fluid and collapsed gallbladder with some pneumobilia is suggestive of cholecystitis. I'm just looking for any form of gallstone ileus. I can't see anything at this moment in stage. I'm just looking at there is post-cholecystectomy clips as well, I believe, here. So this patient has had probably a resection of the gallbladder.
Are very important life-saving signs. finding. When you are
Okay.
scrolling, and miss many life-saving
Life-saving. Okay.
find. Mm.
So I'm just trying to look at the vessels and the vasculature.
Patient has severe post-operative pain.
Okay, severe post-operative pain. I'm just looking at, I think there is some,
Don't worry. Okay, this is pancreatic stem.
yeah,
Will not make
pancreatic.
the patient die. Yes.
Yeah, yeah. I'm just looking at the rest.
Stop, Dr.
Can
F.
I
Stop. Stop here. What
yeah,
happened here? What
I
happened
think
here?
there is
Leave the mouth. Leave
pneumoperi
the mouth. Leave the mouth. What?
pneumoperitoneum.
Yes,
Yeah.
pneumoperitoneum and
Mhm.
some earlocules here. Okay.
Yes. Yeah.
And what is this?
There
What
is
is this?
what is this? As in, there
What
seems
is
to be
this?
some thickening of the
Not sickening.
perforation. Just looking at
Step by
the.
step. What is this?
I'm not sure which side you're looking at or want me to look at. Sorry,
Leave the
I'm not.
mouth. Leave the mouth.
Yeah.
This pre-splenic, pre-hepatic. What is
Free
what
fluid.
scene?
Yeah, free fluid. So subcapsular free
Okay.
fluid.
And you said, see, you said there are surgical clips here. Correct. So connect the finding.
Sure.
See,
So it's probably
connect the finding.
yes, I can see. I can see it. Sorry, I can see it now. There is an area seen of what I believe is possibly a perforated or dehiscence of the anastomosis that has caused the free fluid adjacent. I think it's seen in this location in the left anterior small bowel loop that I can see, and there is a collection around that area
So
with
your
a
final
lot.
diagnosis. Final diagnosis.
So final diagnosis in this case would be with the history of anastomotic clips. This could be anastomotic dehiscence, causing contents of the small bowel to be in the free intraperitoneal space, which is concerning. This is an urgent surgical review. They may need to have debrine washout of the abdomen, and they may need to go in and review the anastomotic suture clips.
Thank you, doctor. You did very well.
Sorry, I didn't. I looked at
No
the
problem. See, my
limit.
colleagues, the cases is difficult. I select some cases for some benefit. Okay. If I bring some cases with some ideas, case scenario, post-surgical like this, it is not easy case. Why? All of you want to make a maximum benefit from this online time. Okay. But take a home
Yes.
message, all of you, my doctors, please, when you start scrolling, when you reach to the diaphragm, please look for pneumoprotomy. This is the most important. The examiner will not be happy if you detect some sickening there or here in the stomach, in the esophagus, but if you missed this, a lot of pneumoperitoneum, he will be angry against you. Okay?
Yes. Yeah.
This is a post-operative. And I said in the beginning of the history, post-operative plus pneumoperitoneum. And please, my colleagues, when you came to an area of finding, don't escape. Most of you go down, 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 down. Okay, nothing here. Please, first, when you go here, even first time, you see, make a whole scan. You see the whole scan. Then please return again here. This is the site. This is the key. This is the pathology. What happened here? Some fluid collection. Okay, surrounding one bowel. Okay, very nice. Oh, doctor, I find one clips. So
Yeah.
connect what you're finding. Fluid collection surrounding the site of operation plus pneumoprotein. See how many pockets of gases? So, doctor, this is almost leakage. Like this, you will finish the case very smoothly. Then you can ask the examiner, I will change to long window, the management I will call. Okay. Okay, all of this are appreciated, but not appreciated before giving me a good logic diagnosis. Next candidate,
Thank you.
welcome. This is a
Hello.
perforation or a leakage of a gastrojejunostomy. Doctor, I don't know the name of operation. Okay, tell the examiner, leave the mouse, please. Leave the mouse. Tell the examiner the site of anastomosis or operation is leaking, perforated. Okay, the site of operation, there are leakage. Like this, he will be happy. He will be happy, okay? See my colleagues here. Then try to ask for another planes. Try to ask for other. See my colleagues. This is the stomach. Down. There are a longitudinal bowel. Down. So this is gastrojejunostomy. Again, this is the stomach. Some diaphragmatic, and there are some rheogae, and is connected here with something longitudinal, another bowel. See? Okay.
See.
So this is
Yeah.
a gastrojejunostomy. Thank you so much.
Thank you.
Next candidate, welcome.
Hello.
Welcome.
65-year male, epigastric pain and weight loss. So this is
Can
case.
you can I scroll for you, or you can?
Sir, I am requesting.
Okay.
Sir, I have requested.
Yes, 65-year-old male patient with epigastric pain and weight loss. Go on. This is an ultrasound.
Okay, these are these are ultrasound grayscale images of the liver in the right hypochondrium. I can appreciate that there are multiple low echogenicity solid nodules involving both lobes of the liver. The gallbladder
Nodules or
looks
focal lesions? Nodules or focal lesions?
focal lesions. There are focal
Yes.
lesions, low echogenicity solid focal lesions involving both lobes of the liver. The gallbladder seems unremarkable. I'm looking for the intrahepatic biliary channel. They are not seen dilated. Portal vein, hepatic vein, and IVC are unremarkable, as is
What's
the portal
your
vein.
differential diagnosis?
In this diffuse multiple focal lesions in the liver, these could represent metastasis, most likely diagnosis. I will look for the primary. If this is the first presentation of the patient, I will
No primary.
request.
This is the first presentation. What will you do next?
Okay, I will suggest staging CT, the CT chest, and also staging CT to look for primary.
Before staging CT.
I will inform the finding to the referring physician and will suggest also CT abdomen and pelvis.
Yes.
CT abdomen and pelvis. Triphasic, multiphasic CT abdomen for characterization of these hepatic lesions. So these are contrast enhanced axial CT sections in the early venous and the late portal, late arterial phase. Sir, in this I can, there is redemonstration of multiple low density focal hepatic lesions involving both lobes of the liver. I will like to see the arterial phase if available. However, these look, again, the findings are suggestive of more likely favoring metastasis. I am looking for the primary. Can I scroll myself, or you will scroll?
Yes. You can.
Okay. Okay, I'm scrolling from top to down.
Okay.
There are few small cystic nodules in the thyroid. However, these are concomitant findings. There are also small, non-significant size mediastinal lymph nodes. As this is a male patient. So I'm going down. Yeah, in the abdomen, I'm looking for the adrenals. The adrenals also seem to be unremarkable. The
What else?
there is, I think this is in the region of the gastric antrum. There is thickening, diffuse thickening and neural involvement with the with contraction of the body of the gastric fundus. Also, I can appreciate that there is a fat stranding in the perigastric region, in the region of the lesser sac. I'm looking for any enlarged lymph nodes. I think I couldn't find any enlarged lymph nodes in this scan. So in this case, in my routine practice, I will also like to see the lung window and the bone window to rule out any intrapulmonary and the bony metastasis. So in confines of this current examination, there is in summary, there is evidence of thickening of the gastric. Yes, thank you. This is a lung window, axial sections, bilateral lung fields. They are devoid of any metastatic deposits or nodules or other foci. So there is no evidence of lung metastasis. So in summary, in this patient with multiple focal hepatic lesions, there is a presence of uh, uh, infiltrative lesion involving the body of the stomach, causing thickening with a mild perigastric fat stranding. So likely diagnosis is gastric carcinoma, adenocarcinoma with the liver metastasis. So I will inform the finding to the referring physician, who will suggest referral to the gastroenterologist team and will suggest endoscopy and biopsy for tissue diagnosis. And I will refer the case to the also gastro-onco. This patient also needs referral to the gastro-onco MDT for further management and further staging. Thank you.
Thank you, doctor, so much. Really, you impressed me so much. Thank you so much.
Thank
This
you.
is a case of a stomach cancer, whatever it will be. Okay, because the pathology were surprising. Okay, you look at the ultrasound and you smash the case very well, and then you did very well when you pick up. Not the metastasis. The metastasis is very obvious, but here, see the stomach. At least this is not a normal stomach. See, this is not a normal collapsed stomach. One colleague will tell me, doctor, this is collapsed. Okay, but even the collapsed stomach, do you expect it is acceptable in collapsed stomach? Leave the mouse, please, doctor. Leave the mouse. Doctor, leave the mouse. See, this is not acceptable. There are a mass here, a lesion here. Please leave the mouse, doctor, my doctor. Here, there are abnormality here. This is abnormal thickening here at the greater curvature. So the primary in the stomach. Surprisingly, it was a gastric lymphoma. Doctor, if I told the examiner it is gastric carcinoma, no problem. No problem. Next candidate, please be ready. Last candidate, please leave the mouse. Leave the mouse because you are still moving my control my. Okay, my colleagues. So this is a gastric malignancy with liver metastasis. Thank you so much. You did very well. Next.
Thank you, sir.
Assalamu alaikum, sir. I'm the next candidate.
You ready?
Okay.
Scroll. Yes.
Yes, sir. I have requested the remote control. Okay, so okay, so I'm presented with CT scan, non-contrast, axial images, and I will first of all scroll the top and then start commenting. Okay, so I can see that there is moderate to gross amount of ascites can be seen, and stomach is distended with the oral contrast. And as I scroll down, I can appreciate that there are changes of mesenteric stranding and some momental thickening is noted. And okay, I'm scrolling down, and the contrast of specified large bowel loops are unremarkable. And again, I can see changes of mental kicking along the anterolateral abdominal wall, and loculated ascites is noted. And as I scroll down, the visualized opacified small bubble loops with oral contrast are unremarkable. Uh, so, okay. So the pelvis is not included in the provided non-contrast study, and I can see that there is a moderate amount of surgery fluid along with the omental caking and thickening is noted, and I would like to review this on the post-contrast study.
Yes. On. Select it.
Hello?
Yes, select.
Okay, okay. Okay, so these are the post-contrast images. Okay. So again, visualized lungs in the confinement of the mediastinal window shows no gross abnormality. And then I can appreciate that there is a moderate amount of ascites that can be seen. And okay, okay, sir, at this point, I have a suspicion of break in the sorry discontinuity in the it's oh no, it's jump. The images are jumping. Okay, okay. Sir, I have a suspicion of some discontinuity in the posterior wall of the stomach, from which there is leakage of the oral contrast. No, sorry.
Don't worry about it, doctor.
Okay, 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 okay. Sir, also there is a hypointense area noted in the uh, pancreas, and
Excellent. 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 So,
sir, so this is likely, sir, fully enhancing adenocarcinoma of the pancreas. And now I
excellent.
would look for any other, I would scan the liver once again to look for any hepatic deposit. And
Don't worry about the liver. Look at the peritoneum here. Anterior
sorry, sir?
mesentery. Don't worry about the liver. Look at
Okay,
the
okay,
anterior
okay,
mesentery.
okay, okay, sir.
Stop here. Stop here. What happened? What happened for the mesentery?
Then in the mesentery,
Yes,
there
anterior.
are changes of omental kicking and
Yes,
uh, yes, sir,
excellent.
omental kicking is there, sir, which I mentioned earlier in the along the anterolateral abdominal wall. And sir,
Excellent.
other than that,
Give me a diagnosis, please.
sir, so this is a likely a case of pancreatic carcinoma with
Very wide.
widespread mesenteric metastatic deposit. So I would convey my finding to the referring physician. I would advise a cytic tap correlation, and also refer the patient to the surgical oncology for further workup, as this lesion cannot be approached via ultrasound guided approach. Also, I would or image guided approach. I would advise correlation with the CA 19-19 levels
Thank
for
you,
the
doctor.
confirmation.
Thank you so much. Thank you. Next candidate, be ready. Doctor, you did very well. Very well, really. Really, you impressed me so much. Very
Thank you.
difficult to pick up a pancreatic tumor cancer in an elder patient due to fatty changes. Nearly the pancreas is totally fatty infiltrated. However, today, if you noticed, I'm bringing many pancreatic tumors to concentrate in it. See, there are at least focal bulging here. Focal bulging, hypoenhancing focal bulging, at least, but it is actually this is focal lesion, focal mass lesion. So, beside this ascites, mental caking, the first possibility it is a pancreatic adenocarcinoma with peritoneal metastasis. What is the differential diagnosis between a pancreatic adenocarcinoma is a focal pancreatitis? How to differentiate between both of them? In focal pancreatitis, you must see the pancreatic duct penetrating sign here. What does mean? You must see through this focal thickening or focal bulging, the pancreatic duct traversing the mass. But here the matter is not like this. No any penetrating pancreatic duct. Okay, my colleagues, one of the most important review areas in the abdomen is pancreas. Second is the omentum. See the omentum here? Very obviously, it is infiltrated by metastasis. Next candidate.